Our next speaker is Associate Professor Danielle Ni Chroinin, and who is a consultant geriatrician at Liverpool Hospital, New South Wales, and also a conjoint Associate Professor of South Western Sydney Clinical School and University of New South Wales in Sydney. Danielle holds dual fellowships in geriatric and general medicine and trained in Ireland before moving to Australia. She has multiple publications in peer-reviewed scientific journals to her name and completed her doctoral thesis in the field of stroke medicine, and most of her present research focuses on clinically meaningful, collaborative and multidisciplinary research applying to the care of older persons. Danielle presents regularly at national and international conferences and is passionate about imparting a love of clinical research to students and trainees. On her days off, Danielle is busy as she is at work, her diary filled with children-centric activities and sundry adventures. Now, I'll just check for a thumbs up at this point to see if we've got one. We have a thumbs up. So Danielle is joining us from online. So thanks for coming in, Danielle, and over to you.
Beautiful. Okay, I'm jealous because I'm stuck here in Liverpool, which is a wonderful suburb, but not quite the Sunshine Coast. I'm here to talk on behalf of a wider team. Everyone else is out on leave, scuba diving, etc. So I said I would talk to you all about the delirium reduction analgesic model of care for hip fracture patients. Bit of a mouthful. We call it DRAM-HF. Disclaimer, the name had nothing to do with me. Alwyn likes his whiskey. He thought it would be quirky and cute to call the study DRAM. I rode with it because we have a shared interest in delirium reduction, and what it's called really doesn't matter. My only conflict of interest is that I do try to start enough denosumab to put an average orthopedic surgeon out of business, although I have yet to succeed, but I try my best. Mrs. S, 81-year-old woman, broke her hip. She's confused and combative on the ward day 2 post-op. So if we say about 16,000 Australians, give or take, somewhere between 15 and 20,000, break their hip each year, at about 40% or more develop post-op delirium. That's over 6,000 patients a year with delirium, just like Mrs. S. And in ways, she's one of the lucky ones because she's hyperactive, though we spotted her delirium, because we know that it's often missed. It may be suboptimally managed, but it's possibly preventable. So, hip fracture, not a great diagnosis. I'm presumably singing to the choir. I won't actually sing. Outcomes after hip fracture haven't brilliantly changed in the last couple of decades. And why do these patients do badly? Well, they're older and frailer and often have comorbidities. And sometimes they have an acute precipitant for the fall, which may also contribute to their poorer outcomes after hip fracture. But they often get delirium. They also get other postoperative complications. And if they end up frailer and falling after their hip fracture or in an RACF, these are also associated with increased mortality. But in terms of delirium, it's common, 14% at admission and about 1 in 3 after surgery. Most of the delirium management guidelines talk about some key aspects of care. So assessing cognitive impairment, recognizing delirium, assessing pain and instituting a multimodal management plan, removing delirium triggers, and then treatment interventions if delirium occurs, largely focusing on the triggers. And that antipsychotics should only be used if other non-pharmacological and drug strategies have failed. And I'm not going to wax lyrical about how terrible antipsychotics are, although it's a pet peeve of mine. And most of these can be addressed with a standardized multidisciplinary plan, and that's what the guidelines tell us. How do we fare in delivery of these elements? I mean, you guys are all probably more familiar with the hip fracture report than I am. But if we look at things like preoperative documentation of cognition, pain assessment within 30 minutes, patients getting analgesia by the paramedic or within 30 minutes of ED arrival, and nerve block, in many areas we've gotten better over the past couple of years. But as you can see, there's still quite a bit of room to hit that 100% target. And we may never get to 100%, but we can still get closer. Standardized multidisciplinary plans probably work. There's evidence from several studies. The good old HELP that us geriatricians love to trot out by Inouye et al. Studies such as Martinez's that were that involved families in delivering multifactorial interventions. We know they work, but we don't actually tend to use them in hospital, partly due to problems with resources. We don't have lots of volunteers floating around. Family members come and go, or during COVID were banned altogether. So a lot of these are not actually being used in day-to-day practice on our wards. So what's practical? We decided to look at what we could do, focusing on clinical management and without relying too heavily on some of the niceties that go hand in hand with having lots of volunteers or family members sitting by the bedside 24/7. This is our little plug for the paper that was published in Anesthesia a couple of years ago. And the delirium reduction by analgesia management study was a before and after interventional study with 150 patients in each arm. And I know before and after studies are limited by virtue of the fact that that's what they are, but working within that, we introduced a bundle of care targeting three main issues. So timely and appropriate POD, postoperative delirium diagnosis, multimodal analgesia, and proactive avoidance of POD triggers. These are bad drugs. Geriatricians don't like them. Therefore, they must be bad. Plus, we promoted this bundle of care. So we didn't just say, here's a bundle of care, go have fun. We did workshops so that people got upskilled in doing fibs. We had education sessions talking to people about delirium and the potential advantages of this bundle of care. And we had weekly compliance audits, a little bit of competition going, and had a newsletter. Now, some of you in the room are probably getting your hipster newsletters. They're great. Newsletters help, right? They motivate people. We can see how we're doing. We can see if we're getting better. And they keep a study to the forefront of people's minds. So these are just some pictures from the newsletters that our medical students actually helped design. They did it as part of their ILP studies. This is a flowchart that walks you through what DRAM HF involves from the emergency department through to the ward, through to the operating suite, and then ward admission, with a focus on getting pain controlled and avoiding bad medications, and doing a CAM at the time, even though we've changed to 480 now, but recognizing delirium, so screening for it. Okay, and we assessed 3-day post-operative delirium as our primary outcome measure. We also performed 30 and 60-day follow-up. So for Mrs. S, if we applied the DRAM-HF protocol, we would pretty much be saying assess cognition, control her pain, and avoid bad drugs. Is this likely to improve her outcomes? Well, in our study, oh, I forgot my nice little moving things here. In our study, we found that yes, it did. Okay, so in terms of all patients, in the control group, postoperative delirium at day 3 was 33%, and in the care bundle intervention group, it was 22%. And in patients who were identified as being higher risk, so cognitive impairment, a higher Apache score, a Charlson comorbidity index that was a bit higher, that's the revised CCI, or an EGFR that was lower, those patients had an even better benefit. And an adjusted odds ratio for POD at day 3 across all patients of 2.2. In terms of compliance with elements of the care bundle, so we looked at whether people were giving bad drugs, giving fibs, doing CAMs. In the control group, the emergency department and anesthetics department had a little bit of room for improvement. And we found that they did improve when we introduced the care bundle with its associated promotional features like education sessions and fib workshops. Or the geriatricians. This is to a certain extent some of our bread and butter work. So compliance with these elements was good to begin with and good to end with. So at least we didn't get worse. In terms of secondary outcomes, we didn't see any impact on mortality or any association with mortality, morbidity, walking, or institutionalization. So what about later outcomes? We've just had a paper accepted, which is going to detail these if anyone is super interested or needs bedtime reading. We didn't lose anyone to follow up at 120 days. Thank you very much to all involved, particularly Lynette. Hi, Lynette. And by 120 days, 8% had died and a quarter of survivors were resident in an RACF. Intervention status in the initial study was not associated with 120-day outcomes. Death by 120 days was our primary outcome, and it was not associated with that. Post-operative delirium, however, was independently associated with all of the outcomes that we assessed. So irrespective of whether or not you were in the pre or post part of the interventional study, you were more likely to be dead at 128 days, more likely to be in an RACF, more likely to be frail as per yourself or your family. And if you had developed delirium postoperatively. So we found that coordinated clinical management could reduce the incidence of delirium, at least in a trial setting. Can we build this into our practice? Well, in parallel with the study that we were running for patients, we also surveyed staff. So we gave them a questionnaire 1 month before the study and 1 month after its conclusion. And it was a voluntary questionnaire for staff of participating departments, so orthopedic surgery, anesthetics, emergency medicine, geriatric medicine, and pharmacy. The response rates were okay by survey standards. So by 2 and 3 answered beforehand, by 2 and 3 answered afterwards. We didn't link them. So we were looking at group changes as opposed to individual changes. The respondent characteristics are shown here, pretty good balance of males, females, people across different age groups within a working staff group. Reasonable representation from various departments, roles, and clinical experience. Support for the DRAM-HF concept was high. That's always nice to hear. They were anonymous, so people could have said, we hate this idea, but they didn't. And then we looked at many, many different factors, but just to pick out a couple of them, most people, well, the scoring for DRAM-HF was easy to understand, was reasonably good with a mean Likert score out of 100 of about 77. People were enthusiastic about having additional computer alert systems. We didn't have those. It was paper-based. So we didn't have nice little boxes pinging up on EMR going, hey, this person has a hip fracture. Have you done their DRAM-HF checklist? Most people said that they use guidelines in day-to-day practice. So they felt that guideline-associated protocols are the way to go. They liked the structure. But people actually found it hard to find the guidelines. As I said, we were relying on a paper system and to a certain extent, well, to a large extent still are, unfortunately. And people found that a bit difficult. They would prefer, presumably, to click on a button and have it there. Or a QR code. QR codes are being trotted out across SWS LHD for all our guidelines. So that may be the way to go moving forward. In terms of free text responses, not everyone gave free text responses, but for those who did, that 84, the major limitations that were identified related to cultural inertia and hierarchical system in clinical practice, lack of resources or funding, and workload. And in terms of suggestions to improve implementation, options such as online and video teaching, upskilling nurse practitioners, increasing the role of the pharmacist, and simulation sessions were popular. This is Carol, who's a trainee in geriatric medicine now, living the dream. Okay, so what we learned from the DRAM-HF and the associated barriers and facilitators study was that DRAM-HF did reduce postoperative delirium, especially in people who were at intermediate to high risk. It wasn't associated with better secondary outcomes, but postoperative delirium itself was still associated with poor outcomes, which we all know. We may have been underpowered in the DRAM-HF to detect a difference at 120 days, and it may be that with larger numbers, we would or will find an association between intervention status and 120-day outcomes. Staff enthusiasm for the protocol was generally high, and multiple facilitators and barriers were identified in our institution, and they may not be applicable across the board. And financial factors such as resources and staffing in terms of limitations, but the potential for incentives later on were common themes. So could DRAM-HF work where you work? I don't know. It's up to you, I suppose. Have a think about your local setting. Is this something that might work? What would the local barriers and facilitators be? They'll be different to where I work. We know that guidelines and practice guides can help support locally driven improvements, and to a certain extent, we leveraged off these when we designed DRAM-HF. This is my little plug for the recently launched ACI Orthogeriatric Hip Fracture Care Clinical Practice Guide. And the data that I'm giving you are from Liverpool Hospital. It would be great to see how DRAM-HF would roll out elsewhere. We did ask for money. We put in a TRGS application. We got beyond district, but not any further. I was sad. I'm sure Mrs. S would agree that it would be nice to get some extra funding and get data from more centres other than just Liverpool. And in an RCT setting, that would be great. My budget here doesn't stretch to a step wedge plus a randomised trial at the moment. But if anyone has extra money lying around, give us a shout, But look, if anyone wants to have extra information about Dram HF, we're very friendly out here in Liverpool. This is not what the hospital currently looks like, but apparently it's going to look like this in a couple of years. It's nice, relaxed doctors outside picnicking with their families and cherry blossoms. So I'm looking forward to that. If you don't want to traipse all the way out west, then you can just drop us an email. Here's my email. Here's Alwyn's. He's particularly keen on emails when he's scuba diving. So email him right now, and Lynette's as well. Thank you.